Hello everyone, my name is Giselle Rodriguez and I will be presenting my Capstone project that focuses on improving mental health care for homeless patients in the emergency department. I'll be talking about how coordinated case management and real follow-up care support can help with this type of population, especially in the ER as this is their main source of care. As an ER nurse, it is an ongoing issue that we see. So hopefully by spreading some type of awareness, we can help this issue that we currently see all the time. So a little introduction into my project. We see homelessness and illness interchangeably almost every single day. Many of these patients come in because they don't have access to other type of care, especially mental health services that's really hard to get a hold of. So they just want a safe environment, somewhere where they can feel safe. So this is usually where they stop by. Almost half of the people experiencing some type of mental health care issues are also homeless. So the ED ends up being the safe place that they only can go to where they feel like safe. The problem is that most of these patients, once they get discharged, they're just given like a paper list of resources or references with clinics or numbers, and realistically that can't follow through with that. Sometimes the issue could be just because they don't have transportation, they don't have a cell phone, they don't have any type of way to make calls or ways to get set up in these facilities, so it's almost impossible for them to get help. So constantly we are seeing them again and again because of their needs that are not being met. So this is a never-ending cycle that we just haven't been able to find a resolution to. So hopefully we can see some type of change. The problem is that the ED is built for stabilization, not long-term management, right? So we treat the crisis, the underlying issues don't just go away once they leave our department. So because there's no coordinated follow-up care, patients often end up coming back to us and we're seen in the same position all over once again. And this puts the strain not just on the ED staff, but the patients as well that are there. This is where we have overcrowding, burnout because of the staff, and longer wait times because of little things like this that can be seen if we just follow up with the care. But most importantly, the patients, they're not really getting what they need from us as the staff. They need consistent mental health care and support in navigating all these barriers that they face. So the purpose of this project is to look at how coordinated case management can actually improve these mental health outcomes with these patients. We want to increase the follow-up with resolutions, and we want to reduce the repeat visits of these patients coming back for the same problems. So instead of just cycling through the ED coming in and out, we want to actually provide some type of long-term care that will stabilize for these patients with mental health issues. This aligns with several of our Bachelor of Science and Nursing essentials, especially like patient-centered care, interprofessional collaboration, quality improvement, and using the EBP interventions. All of this contributes to nursing everyday essentials. My PCOT question focuses on homeless adults who come into the ED with mental health care concerns, and whether implementing coordinated case management and follow-up leads to fewer repeat visits and better outcomes compared to just handling them resourceless. This time frame is expected in about 6 months or so, which is usually enough to see a pattern in people that keep coming to the ED and follow-up engagement. Homeless patients, they don't just use the ED for medical emergencies. They come in for safety, warmth, food, to feel protected, right? To feel safe, because they don't have anywhere else to go. Most of these patients don't have a home. The ED becomes their entry point into the healthcare facility and the healthcare system. So this issue, after we stabilize them, there's usually no plan to support them. We just, like I said, we just so used to giving them a reference list or some type of resources and send them off their way to go. So without an actual coordinated follow-up system, it's kind of hard for these patients to reach the services that they need. So this leads to repeated crisis, worsening symptoms, and reoccurring of ED visits, which is not good for them and not good for the hospital, because then that comes with other underlying issues. Based on the literature review, I did have a couple of review studies that we did, but altogether the studies that help support what we see in the practice. It provides structured, ongoing support, makes a major difference in our society. These are just some examples that I listed on my PowerPoint that were used in the paper. Some of them showed integrated care actually reduces ED visits and improves mental health systems. Another literature review showed how nurse-led programs can help build trust and support equity for homeless patients. There was also research that supported case management. Once they follow up, it's a way to reduce these crisis episodes. One showed that when patients help co-design their mental health care services, they engage more. And there's just many resources about how patient advocate programs can also help prevent these repeated ED visits. So same thing, just kind of following through, helping these patients, helping their needs, and actually coordinated with them to see what's the best resolution. So some of my proposed interventions, the intervention is simple, but yet it's powerful. We have to identify all of these homeless patients during triage, right? So that's triage is the main area where we see all of our patients from. So by proposing these interventions, maybe we can have like a behavioral health specialist come in right there next to us in the ED if we suspect somebody's having a mental health crisis. Together working with the nurse that's triaging them and with this behavioral health specialist, we can create a discharge plan that's realistic for them and personalized, specific for their needs, and not just give them a list of random resources or outpatient clinics. We can schedule up follow-up appointments before the patient actually leaves, and whenever possible. We can coordinate transportation if they need one with the handoff, or give them some type of community mental health agency that will be able to reach out to them. This helps us with the patient by actually giving them a plan and not just hope, right? So by doing this in triage, maybe we can limit the wait times, we can limit the burnout staff by doing this with the first care of look that we see in them. Some key stakeholders, the interventions require a team approach, not just a nurse. So we need help from the ED nurses. Maybe we can use behavioral health navigators, social work involved, which already does, but maybe we can have more help. Community mental health partners and hospital leaderships. All of these can help with the problem that we're currently facing. ED nurses were the first point of care of contact that we see with these type of patients. So it's very important that we work together, establish some type of plan, especially with other team, and make an effort with the following stakeholders to hold an important role in fixing this current problem. An implementation plan that we can do, we can train staff. So having some type of workflow or some type of plan that will make this kind of plan a little easier. We could create like secure connection pathways to the ED team and our community nearby partners to stay connected and follow long-term with these patients. We have a behavioral health specialist that I work with, Dr. Navasha Martin from my hospital. So maybe she can go around different areas and training more nurses or the ED nurses for sessions on how to navigate or come up with some type of plan that will help. And yeah, like I said, just building partnerships with other agencies that will work good with this. There, obviously with creating some plans and everything, there's always some barriers. We face many challenges already in the ED. So it's extremely hard to reach patients once we discharge them, especially if they don't have stable phone numbers or if they even have some type of phone or anything that we can get into contact with them. Staffing is an ongoing issue, like I said, in the ED. So one of the departments we're already short-staffed in. So adding more work for these workers will require more funds. So that's another barrier that we have. Transportation is another issue that we face with these patients because it's hard for them to follow up with their appointments, as most have no reliable transportation. Sometimes you can take the bus too, but let alone they probably don't even have funds for the bus routes. And sometimes outpatients as well have usually long wait periods, and some of these patients don't want to wait that long. They don't want to wait months or weeks to get seen. They need help now. So it makes it really hard to help these type of patients. So understanding the barriers can help us create some plans, some strategies from the very beginning before we discharge them to see how exactly they can get the help and resources they need. Our evaluation, so to measure success, we can compare the ED visits before and after intervention to see if the revisits go up or if they've gone down. We can come up with some tracking attentives to follow up with the appointments to see how it's going. It can tell us the navigator, if the navigator documentation is working. Patient feedback is also important too, especially if these patients come back. We want to follow up with them. Or they feel more supported? Is there anything that they think we can help? Do they need to integrate any other type of plans? What went wrong? What went well that we can continue to use for our next ongoing patients and next situations? So hopefully by implementing these, we can have some expected outcomes. If everything goes well, we would expect to see fewer repeat ED visits for patients that are having mental health crisis and services. The patients should feel more supported and more connected through the ED staff, so we should see less strain from this type of recurring crisis visits. Overall, the goal is to have some type of stability for these patients, long-term stability. So helping patients move forward to their recovery, and instead of constantly being in this crisis, will hopefully be best and for everybody if the plan goes well. So we would have fewer repeat ED visits, we would have better follow-up with mental health care services, improved overall stability, less overcrowding in the ED, people are dealing with these crises, and better long-term patient engagement. Dissemination, we should share the results of the ED staff with meetings so that everybody understands the plan, what went wrong, like I said, what's going good, what interventions are working. We can also share findings with other hospital leaderships and under staff maybe at local nursing conferences to see how it's going as well. We could also publish a nursing journal and share our personal experiences with community agency partnerships and see what they face and maybe how we can collaborate with each other. So just being involved with the community and the patients that we see, and like I said, using staff meetings to communicate about this ongoing issue, we can kind of help with a better resolution. Overall, in conclusion, homeless patients with mental health care needs to serve more crisis stabilization long-term. A coordinated case management can give them real support. So using like a behavioral health specialist that deals with this situation and coming up with a better plan can continue with a better continuity of care and a chance at long-term stability. Nurses make, they make everything better, make our patients feel better. So they play a major role in nursing. So by making this possible, by advocating for our patients, educating our patients, and building these strong relationships with these type of patients, we can hopefully straighten the continuity and reduce these ED visits of people coming in for the same thing. So overall, this Capstone project will hope to aim, and maybe the ED can be the first step towards recovery and not just another stop in the cycle of crisis. So hopefully we can see some type of improvements after all. Below I will be attaching my references that I use for this project. Of course, if you have any questions, you feel free to leave them under this video and I will be more than likely to answer them. And hopefully we can see some change with this Capstone project and that we can start implementing soon into our ED department. Thank you. Thank you for watching.